Hello, everybody. I want to go over one of the important aspects of the disorders that can occur in the immune system, and that is autoimmunity. Autoimmunity. And in medicine and science, we use the term auto for self. So autoimmunity refers to the immune system acting against the self, which is bad. We don't want that to happen, and those are referred to as autoimmune diseases. And once somebody has an autoimmune disease, it's not something that goes away. It's something that has to be treated and the effects mitigated for their comfort and for their survival. So just remember, the immune system has to have a couple of things to function normally. First of all, it needs to be able to recognize foreign things, so recognize antigens and pathogens in general. So when something is infected or something is foreign in the body, it needs to be able to recognize that. And not only does it need to be able to recognize something foreign, it also has to remember what that antigen looks like. And that is done in a fashion through acquired immunity, through the processing and display of those antigen fragments to the immune cells in the body, and then the development of specific antibodies and memory cells which recognize that antigen to be able to fight it in the future. The final thing that'll lead us into today that is important for the immune system to know how to do is self-recognition. In order for immune cells to function effectively and to avoid pathologies in the body, the immune system should be able to recognize the difference between a normal, healthy self cell of the organism and an infected cell. When that ability to self-recognize breaks down, that's how we get autoimmune diseases. So autoimmune diseases, there's about 100 types that are recognized right now, and I'm just going to give you a couple of different examples of them. And these are also going to tie into those hypersensitivities that you should have learned. And if you haven't learned them yet, I have a talk on my YouTube channel about the 4 types of hypersensitivities, type 1, 2, 3, 4. And those hypersensitivities form the basis of these autoimmune diseases. There's some sort of breakdown of these normal immune responses, and then you get too much immunity to the self cells. There are autoimmune diseases that exist of the thyroid. There's thyroiditis, where there are essentially these rogue antibodies that they resemble thyroid hormone, which means they bind to thyroid hormone receptors. But remember, the rule in the body is anything covered in that antibody is tagged for destruction. So these antibodies tag cells on the thyroid. The thyroid thinks that they're a normal hormone, but then because they're trying to help, these immune cells come by to attack the cells tagged an antibody, which in this case are healthy thyroid cells. You see this also in Hashimoto's disease, where you get selective destruction of the thyroid. And in Hashimoto's, you can see an interesting kind of change between this hypertrophy and hypertrophy of the thyroid gland. So it gets bigger and then it gets smaller, but in general there's abnormal thyroid hormone release and then thyroid function. Graves' disease is hyperthyroidism to the max, so it's a very overactive thyroid, and in cases of Graves' disease, this is caused by, again, this kind of rogue antibody causing the overproduction of thyroid hormone. And glands work similar to muscles. You might know that a muscle, the more you work it, the bigger it gets. Same thing with endocrine glands. The more hormone they make and then release, the bigger the gland gets. So you see a lot of hypertrophy of the thyroid gland in Graves' disease, and then a hugely overactive thyroid with all of the classical symptoms of hyperthyroidism. In bone, there's rheumatoid arthritis, polymyalgia rheumatica, We'll talk about rheumatoid specifically in this lecture briefly. We've got different muscular autoimmune diseases like ankylosing spondylitis. We've got skin disorders like psoriasis, eczema, vitiligo, scleroderma, fibromyalgia in the lungs, neuropathies in the nerves. Pretty well-known ones, I would say, are celiac, Crohn's, ulcerative colitis, and type 1 diabetes. The leukemias, lupus, hemolytic types of disorders, and in the brain, we've got Guillain-Barre, possible autism, multiple sclerosis. So the point being that there are autoimmune disorders that are possible in essentially every organ system in the body, and they are really classified by the fact, or characterized by the fact, that we have immune cells attacking these normal, healthy self cells of the body, causing destruction to them, and then limiting their functionality. Okay, so as I mentioned a little while ago, I'm just going to give you some different examples of autoimmune diseases. We have Hashimoto's thyroiditis. Itis, remember, is inflammation of, so inflammation of the thyroid. And in Hashimoto's disease, like all thyroid disorders, this is most commonly seen in middle-aged women. And we see, again, this interesting variation between hypertrophy and then a change in size, sometimes an atrophy of the thyroid. But in general, what we see is hypothyroidism, which is an underactive thyroid characterized by a low secretion of T3 and T4, so thyroid hormone, and then the actions of thyroid hormone in the body. And thyroid hormone is mainly a metabolic type of hormone, so it increases the heart rate, it increases the binding capabilities of catecholamines, so your dopamine, epinephrine, and norepinephrine. It increases caloric expenditure, the metabolic rate in general. So you're going to see hypothyroidism associated with low metabolic output. Goiter is a term for a diffusely enlarged thyroid, and you can see, as I mentioned on the slide previously, an overactive gland becoming hypertrophic because it's overactive. It's making so much hormone that it needs more cells to churn out hormone, so therefore it gets bigger, it makes more cells, and the existing cells get bigger. You can also see glands get bigger, like the thyroid in this case, for example. Here's a thyroid. That looks pretty good, kind of like a bow tie. When there is overactivation of hormones binding to the thyroid. So when we talk about receptors, those are just areas on a cell. So if let's pretend these are receptors on cells, so they're obviously not that big. They're microscopic, but let's look at them. In order for the thyroid to crank out T3 and T4, there's a hormone that's released from the pituitary. It's got a great name. It's called thyroid stimulating hormone, or TSH for short. And TSH is a substance, which means that it itself is a ligand, meaning it binds to a receptor. So TSH would bind to a receptor, and the result of that would be the release of T3 and T4 from the thyroid into the bloodstream. Remember that the endocrine system works on a negative feedback, meaning that the level of T3 and T4, when it's normal, will go back and tell the brain, specifically the hypothalamus, that levels in the bloodstream are adequate and it doesn't need to make any more hormone for thyroid hormone release. However, if there's low amounts of T3 and T4, I'm sorry, lady, for drawing on your head, sorry. But if there's low amounts of T3 and T4, that's going to feed back to the hypothalamus and say, we don't have enough, we need more. And then the hypothalamus will tell the pituitary that it needs to get its act together and make more hormone so that we have normal levels, normal homeostatic levels of thyroid hormone. So the pituitary will increase the amount of TSH that it makes, hoping that the more TSH there is, the more T3 and T4 it will have. But if that T3 and T4 is never at a homeostatic level, we're going to get this constant feedback to the brain that we don't have enough, and then there will be a large increase in the amount of TSH that's released. Again, because TSH is a substance, it's binding to receptors, and if there's a constant increase in the amount of TSH, it's going to need more receptors to bind to. Those receptors are part of the cell membrane. So if we need more receptors to bind this increased level of TSH, those cells are going to reproduce, they're going to keep dividing, and they're going to make copies of themselves to increase the numbers of receptors available. That means more cells, and that means a bigger thyroid, a hypertrophic thyroid. And in Hashimoto's thyroiditis, this is a lack of a precursor to T3 and T4, which means that we get inadequate release of T3 and T4, and then that feedback loop that I just mentioned, where TSH levels are really high because the body is trying to do what it's supposed to do and increase those levels of T4. This is a type 2 hypersensitivity. Remember your type 2 hypersensitivities, that's your antibody-dependent cellular cytotoxicity, whereby any cell that is covered in antibody is tagged for destruction. So this involves antibodies to thyroglobulin, which is the large precursor to T3 and T4 that's present inside of the follicle that is cleaved into pieces. I'm trying not to get too in depth here. It's cleaved into pieces for T3 and T4 to be liberated and then released into the bloodstream. So if you're destroying essentially the precursor, that thyroglobulin, which exists inside of the follicle, if it's covered in antibody, then it's going to be destroyed. So thyroglobulin destruction then is going to lead to inadequate T3, T4, and then this inadequate feedback loop stimulating the thyroid to make T3, T4, but ends up just making the thyroid hypertrophic. Okay, then we have lupus, SLE for short, systemic lupus erythematosus. So this is a disorder which is characterized by the destruction or the existence, of what we call ANAs, or anti-nuclear antibodies. Nuclear is referring to the nucleic material of cells. So in this case, we have antibodies developed to specific components of the DNA. And this is something that causes a large amount of widespread downstream effects because of the non-specificity of ANA antibodies. Really, all cells in the body have, nuclear material, so they can all be targeted by ANAs. Okay, so you'll see this characteristic face rash in lupus. I'm drawing it in for you. So sometimes it's called the butterfly rash because of its appearance mirroring that of a butterfly with its wings open, which goes across the forehead and then the bridge of the nose to both cheeks. Where this name comes from, mala means cheeks. So when you see words with mala in it, it's referring to cheeks. So lupus comes from the Greek term lupe, which means wolf. If you like Harry Potter like I do, you might remember that Professor Lupin, he was a werewolf, and that comes from the word lupe. So lupus is also derived from lupe. So not only is this called a butterfly rash, this is also called a wolf-like rash, in that it resembles the coloring that you would see on a wolf. Okay. In this disorder, again, we have these A antibodies which target all types of cells, and this is a type 3 hypersensitivity, and you might remember that type 3 hypersensitivities are dependent on those antibody antigen complexes. So we get the formation of these tiny, tiny complexes that are too small to be carried away by the bloodstream down to the spleen and liver for neutralization. So instead, they get stuck in the microcirculature. When these things get stuck in the vessel, so if this is a vessel wall with its epithelium, and here's a little antibody complex. Remember, every cell tagged with antibody is tagged for destruction. So even though this is a healthy vessel with a healthy endothelial lining, macrophages and natural killer cells will see the antibody and start to kill and eat away at the cell covered in antibody, which is very likely in the bloodstream because they get stuck in the microcirculation. So because there's microcirculation everywhere, again, you see very widespread damage. So you see all kinds of blood supplies being affected. You see this being one of the driving factors behind this red, wolf-like or butterfly-like rash. You can imagine, and you can even see this redness here, if there is destruction of the microcirculature, you'll get bleeding and redness out into the area. You see this happening within the glomeruli of the kidneys, within the articular tissue, within the lungs themselves, within the heart itself. We get the selective destruction of healthy tissues because of these antigen and antibody complexes. So SLE we consider mainly the result of a type 3 hypersensitivity. Okay, we also have rheumatoid arthritis. This is when there is an antibody that is specific to a serum component. And when this antibody develops to the serum component, then we get the destruction of this natural component of the serum in the areas where that exists. So normal tissue is tagged with antibody and then targeted by these immune cells. So in rheumatoid arthritis, you see this propagation of the immune response in the articular tissues. So itis, again, inflammation, and arth is referring to the articular tissues, the joint tissues, specifically the joint lining. In this disorder, again, you get the antibody. So here's a B cell making antibodies, and this antibody is going to attach itself to a variety of natural healthy cells in the joint space. Okay, one of the side effects of having this continued immune response within the joint, so one of the things you see here, PGE2, that's a type of prostaglandin, that's a pro-inflammatory protein. Whenever you have prostaglandin, that drives down the pH of whatever environment it's in. So pro-inflammatory hormones, inflammatory things in general, are low pH. They're highly acidic. Joint spaces themselves have low pH. They're slightly more acidic than the rest of the body. So when you have this kind of constant immune system overactivation in the joint space, you get, imagine like acid being washed over the joints all of the time. You start to get destruction of the bones themselves and then inflammation of this, articular tissue. One of the side effects of having this acidic environment because of this inflammatory protein that's being, or almost hormone that's being constantly created in this area, you get this bone destruction, and there's something that forms called reactive bone, kind of like bone spurs. You see that a little bit here. You get a full displacement and abnormalities in the appearance of bones at the level of the joint, which is propagated by this acidic environment, this creation of reactive or extra bone. You'll see that referred to as a pannus. And this is really characterized by a type 2 hypersensitivity, where we get this development of antibody to this natural component of articular tissue, and then an ongoing persistent immune response to this. So this is pretty progressed advanced rheumatoid arthritis, where you see an actual disfiguration of the bones within the joint spaces. Rheumatic arthritis is a systemic disease, so it doesn't just affect the joints. We have a disease state that goes along with this, especially when the immune system is compromised. Because one of the main ways we treat rheumatoid arthritis is through immunosuppressive medications to try to prevent or at least decrease this constant autoimmune response by dampening down our natural immune system. Okay, we'll end, I think, go away. We'll end with a disorder of the neural tissue called multiple sclerosis. Osis is development of, and scler means hardening. In multiple sclerosis, there's antibodies that develop to the myelin. So if you remember, with neural tissue, we have axons, and they are encased in this fatty myelin. And there's nerves that exist without myelin. There's nothing wrong with them. It just means that things move more slowly down them. Nerves that are encased in this nice fatty cholesterol myelin, they have a really quick conduction, whereby a message, it hops over the spaces essentially between these myelins. They're called the nodes of Ranvier, which is fun to say. And it's a lot faster than a nervous impulse traveling bit by bit by bit down a nerve without myelin. And a good way to think about this transmission is like if this is your laptop and this is the cord that plugs it into the wall. Here's a little plug. That looks good. All right, so myelin is like the plastic or rubber casing on that cord. It means that the electricity is going to go from the wall to your laptop, and it's going to go pretty quickly, and it's going to be safe, and you can touch this cord all you want, and you're going to be fine. Well, you're not going to be electrocuted. We'll leave it at that. Okay, however, if for whatever reason, like let's say you've got a cat like mine that like chews away at portions of this, and now we're missing in this area a bit of that casing, and now this is just an exposed wire. That means that that charge can go out in all directions. We're not going to have this nice charge going all the way from the wall to your laptop. We have this area of lost encasing. That also means if you touch this, you can get shocked. That tells you that the charge isn't going from point A to point B. It can diffuse out in all directions. So that's going to limit the ability of things to go the way that they need to from point A to point B. So that brings us then to multiple sclerosis. So multiple sclerosis, again, it is something that develops antibodies against myelin. So if antibodies are here tagging the myelin, then macrophages, different phage cells are going to come by and they're going to eat away at this myelin until you have something resembling this. You've got an exposed fiber because the myelin has been tagged for destruction and eaten away at by the immune cells. So this is something, again, that is progressive. Once this disease starts, it progresses, meaning it gets worse and worse, unless somebody is on a great medication regimen and you never see a reduction in symptoms, which would be lovely to see. Multiple sclerosis is central, meaning that it affects the CNS, the central nervous system. That's different than like Lou Gehrig's disease, for example, amyotrophic lateral sclerosis. Lateral means to the side of the central nervous system. If this is the brain and this is the spinal cord, then that's your central nervous system. These lateral nerves, these peripheral nerves going out to the various places like skeletal muscles in the system, those are what are affected in ALS. So ALS is a form of MS. It's in the same family. It's still going to be the inflammation and the targeted damage to nerves. ALS is peripheral, where MS is central. Because this is again an autoimmune disorder, when this is well under, or at least a little bit under control with medication and therapy through immunosuppressive drugs, individuals still suffer from flares in their diseases, whereby symptoms get worse for some period of time. And that happens generally when there is suppression or an overactivation, essentially, of the immune system. Every time there is a flare where there's this small or large portion of time where there is damage to the nerves, there is more and more damage done. There's only so much myelin, especially in the central nervous system. There's not a really good way to regenerate nerves, especially like spinal nerves and nerves along the visual pathways. Once those are gone, they're gone. Once they're damaged, they're damaged. So the treatment goal with MS would really be to decrease the variability in the severity or the intensity of the immune response, to limit the number of flares, thereby limiting the damage to these myelinated nerves. So that was just a brief overview of the autoimmune disorders, their basis, and the way that they are linked to hypersensitivities. Having drawn this out for you, I hope that you can guess or make an assumption what hypersensitivity MS is a manifestation of, in that there are antibodies sitting on healthy tissue and then being targeted by the healthy immune system. Okay, that's it for your autoimmune diseases, everyone. Stay smart. So, yep.